So we started this procedure only from 2 years ago. So only the 2 years experience, but we also focus on the chronic pain. So I understood that this condition is very complex and the diagnosis is sometimes very hard, and some underlying other mechanism of pain, or so it's not simple. But I will introduce a brief background. The first, pelvic congestion syndrome is a frequent overlooked gynecological complaint and characterized by persistent dull pelvic pain for more than 6 months, and exacerbated by walking, prolonged standing, prolonged walking, or sitting, or lifting, or something. And ovarian vein embolization is recommended currently with a high technical success rate, and symptom improved reported during about 60 to 90%. Sorry, maybe you cannot see it. So the cause of PCS is usually the insufficiency of venous valve of ovarian vein, especially the left one, because the angle of the left ovarian vein is right, and the right, compared to the right ovarian vein, the left ovarian vein have a relatively dull angle and easy to reflux. So usually the left ovarian vein is the target cells. And there's a communication with the right and the left and around the pelvic, and also internal iliac vein. And we can identify the dilated ovarian vein by the contrast-enhanced CT or MR venography. And sometimes there is a famous secondary cause of PCS, is like abnormality of artery and vein. Famous one is nutcracker and the May-Turner syndrome. And there is a Hironuma classification, famous classification of contrast-enhanced CT, and grade 1 is just reflux from left ovarian, and grade 2 retrograde flow, and ipsilateral parauterine veins, and grade 3 is contralateral size reflux. So the right A is grade 1, and B is grade 2, and C is grade 3. And this ovarian vein embolization first reported in 1993. And now various types of embolic agents are used, from the coil, sclerosing agent, glue, and plugs on the coil. So this is venous angiography before embolization, and advanced catheter, and puts coils, lots of coils, and after embolization, like this. So let me introduce our system. We use a 4-flange long sheath from right femoral vein and not artery, vein. And the shape is Jadkin's right 2.5. And we use a 1.9 French microcatheter. And we use this guide wire and the coils. So we only use coil. And let me give you one case, 66 years old female, over 10 years history of lower abdominal pain, persistent pain, and NRS was 8, and disrupting sleep. And typically the symptom of lower abdominal pain in PCS is left side, but these patients have right side pain. This is a CT, contrast-enhanced CT. We can see the dilated left ovarian vein. There was no dilated right ovarian vein, so only the left side was dilated. And we can see the reflux of contrast-enhanced by dynamic CT, like this. And we also can see the dilated left ovarian vein around the like pelvic area, like this. So maybe many IR physicians will perform not only CT but also MRI, but we didn't do that, and only by contrast-enhanced CT, and go to the embolization procedure. First, we check the reflux of ovarian vein from the left side like this. So we can see the renal vein. We perform the angiography from renal vein, and we can see the reflux, strong reflux to the pelvic area like this. So we can finally diagnose as pelvic congestion syndrome. And we inserted the microcatheter. We inserted the catheter to the pelvic area and performed the angiography here. So you can see we can see the dilated pelvic area vein, and so we can diagnose this is grade 2. And after that, began to put the coil using the 6 millimeter or 8 millimeter coils like this, starting in the pelvic area, and after that, put some more coil. And finally, we embolized the ovarian vein and about 1.5 vertebral body from the left renal vein like this. So we finished putting coil and perform angiography again. So we didn't recognize reflux and stop the refluxing, and the size of the ovarian vein is getting very small. So we finished the procedure, and it was 2023, about 1 year ago, an embolization procedure. And 3 days later, she told me that lower abdominal pain or hematuria and diagnosed with cystitis, but improved after the antibiotics. And 1 month later, the pain was improved from 10 to 2. And from now, currently maintaining the good condition. We keep to doing the physical therapy after this procedure. So this is a case of good cause. But the second cause is a recurrent case. 40 years old female, low back pain for 4 years, and left abdominal pain. And the pain worsened when prolonged sitting, and prescribed herbal medicine, but no improvement. So we performed the CT, and we can see the very weak dilated left ovarian vein like this, and also the reflux to the ovarian vein. So again, we use the same system, and advanced the 4 French catheter into the left ovarian vein, and we can see the very weak reflux, and we also can see the contralateral side right ovarian vein, so we can diagnose this is grade 3 PCS. First, we advance the microcatheter into the near the uterine and put the coil. We start with basically we start with a relatively small coil, and see what happened and change the size, the bigger one. Like this, and after that, we move the catheter to the proximal point, and we notice that unusual the ovarian vein have some plexus or some several lumen. So we notice that we feel the first lumen, but we still remaining the second lumen. So we inserted the microcatheter and performed putting the coil again. And finally, we noticed that there is no reflux. So basically, we try to embolize as high as possible, but this time we only do this area. So endpoint is always important. We want to stop this area, 1 vertebral body or 1.5 vertebral body from the left renal vein, but the endpoint was relatively distal. So we performed this procedure the last year, July and October. The symptom partially improved, but in this year, after 1 year, symptom recurred, considering the recanalize or the recurrence of reflux. So we checked performed the angiography. This is angiography when the 1 year later, so we can see the remaining lumen. I think this is some anastomosis, and so we put the coil more from here. So our previous endpoint was more distal, so we want to cover this area. So finally, we put the final coil here, and we finish the procedure. So this is the angiography after the procedure, and after that, the patient's pain improved, much improved, and maintained from now. So maybe the recurrence was due to the recurrence of reflux. So complete embolization along the entire length is very essential, and I recommend to do from the confluence of the renal vein to 1.5 vertebral bodies causal. And when we move the catheter, parent catheter or microcatheter, we have to be careful not to move too much, because once we move, we cannot insert more easily. So I recommend to carefully move and put the coil. And the good endpoint is 1.5 vertebral body caudal from the origin of left ovarian. This is our review of our 20 cases. The mean age was 50, and technical success was 100%, but there was no severe adverse events, and mild adverse events, including the procedural pelvic pain, and the overall clinical success. It depends on the definition of clinical success, but improvement, at least NRS 2 or more, was 75%, including partial improvement. But some patients have only 10 to 7 or 10 to 8, or, yeah. So it's sometimes very partial. But some patients have dramatically improved. So from the literature, the technical success rate reported 96 or 98, and there was no death or the severe adverse events, but coil migration described at 1.6%, and effectiveness reported to 60 to 100%. And let me give you other non-typical symptom patients. 38, female, left lower abdominal pain for 10 years, and the pain triggered by prolonged sitting or sexual intercourse. So it's very similar to the PCS symptom. NRS was 8, and every other day the pain becomes so severe as she described. So we performed the contrast-enhanced CT, but no sign of ovarian vein dilation. So only the functional cyst and the hepatic cyst. So we consider that some other mechanism of pain. And of course, we do, as you know, we do the inflammation embolization. So we tried, we explained to test the evidence of inflammatory pain. So we performed. The diagnosis was very difficult, but we performed the angiography from artery and internal pudendal artery and left superior vesical artery, but there was no finding and there was no evoked pain. But in the uterine artery, when we infuse the contrast enhanced, the patients feel the evoked pain from the left uterine artery, so we infuse the imipenem from here, so 2 cc, and after that, significantly improves the pain symptom. So I think some patients have dilated ovarian pain, some patients do not have dilated ovarian pain, but the pelvic pain symptom is very complex. So I think the underlying other cause is also involved in this condition. So the future technical challenges, including the need for treatment of bilateral internal iliac vein or contralateral side. So we only do the left ovarian vein embolization. Maybe some patients have recurrence, and maybe some patients we should do the bilateral or not, but we didn't do that. And the selection of embolic material, we only use a coil, but some physicians use coil and or plug or a liquid, so we don't know yet which is better or not. Finally, I want to introduce you the next year BENTI meeting is an international, not only MSK, but also pain and inflammation and embolization or nerve ablation Congress. And last day we decided the venue is JP Tower is very close to Tokyo Station, and Kite is very near to the Tokyo Station, so very accessible. Please remember this event. Thank you very much.